Thank you. Perfect. I think you can see my screen. Yeah. All right. Today we are going to review on the progress review of our palliative care services, which we started for nearly more than 6 months now.
Yeah.
So
January
January
2022 till now.
Till now. All right. So I just want to go in a background of what is palliative care, because the definition is quite broad across the globe, and it is well established in the developed countries, but it's merging in the South Asian region. So the Ministry of Health, Sri Lanka, and WHO define what is palliative care is just a special medical service which focus on the relieving symptoms, pain, and stress, emotional stress caused by the serious illness. So most have proper different concept. This could be a cancer care. This, if palliative care is initiated, the patient is going to die. So it's actually not like that. It can be any serious illnesses which we are relieving and making the patient comfortable. And this is not only we care for the patients, but also to the family members. And this we are trying to provide this palliative care along with the normal service. This is not in a different entity. And this palliative care is not always applied to the oncology, but it also non-oncological conditions like non-communicable diseases, dementia, and elderly care, child health, and long-term disease like heart failure. So in our program also, most 95% of the patients are non-oncological, mostly are geriatrics, and most are affected by the non-communicable diseases. So what is the estimate the palliative care needs in Sri Lanka? So the WHO has had estimated that around 0.1 million people need a palliative care each year. And there is no real data we have across the country. This is just a rough estimation. But we predict these palliative care services tend to be increased over the time due to aging population and increasing number of chronic diseases among this elderly vulnerable population. So the palliative care needs are growing in Sri Lanka and all other South Asian region. As you can see in this demographic figure, in 2050, we expect the elderly age population to be a little bit higher compared to now. So how about the access to the palliative care service? The College of Oncology, Sri Lanka, has estimated that only less than 1% of the patient receive the adequate palliative care services in Sri Lanka, because there is limited special centers are limited, and like rural and home-based access to the palliative care services is remain minimal. If you take in Mullaitivu district or in the northern part, very limited hospitals and primary healthcare centers are providing palliative care services. So in terms of healthcare access in Mullaitivu district is very limited because of the low social economical states of the patients, and also lack of transportation and proper roads, and limited health awareness and literacy. So I just want to take to a case where to define these all three problems. So we were visiting one patient, 69 years old patient, who was previously healthy, and he slipped and fall 3 years back. Since then, he was bedridden. Their family members tried to seek help from the hospitals, well-wishers, and the family communities, but none of them tried to help them because there is no proper access to road to their house. Even when we visit the first time, we have to walk nearly like 15 minutes to reach their house because the ambulance can't go. Since then, for the 3 years, he is bedbounded just because he fought. He might have a neck of the femur fracture or something, a fracture. That's why he couldn't able to walk. This patient could able to have a normal life, but couldn't have access to the healthcare. Because of that, he is bedridden. This is a similar story of the most of the patients we visit so far. So here you can see how our service is impacting each patient because his wife has. I'm so grateful that the doctors and nurses officers visited our house. None of them had checked my husband before, and he is seeking for help to get a proper treatment, um, and wants him to have a normal life. But then again, so we had a regular follow-up. His blood pressure was high, and we had a regular follow-up. We were controlling medical. So last month, our palliative care nurse, Mr. Muralidharan, has gone to the house to find some transportation arrangements to take him to our hospital. However, when he gone and discussed, then his son comes into the play, and he was saying he is reluctant to send his father to the hospital because he believes that it's not worth. We can't. There is no any positive things that he can able to go walk back again and get back to the normal life. He is already very old person. So such a lack of awareness on the health is prevalent in this Mullaitivu district. So our mission for our palliative care program is that to provide compassion, accessible and patient-centered palliative care services to these underprivileged communities in the Mullaitivu district, because these patients are so vulnerable because they are affected by the war. So we aim to improve the quality of the life through the holistic approach, approaching their physical, emotion, and social needs. So we want the patient to receive a dignified and compassionate care. We not only want to care for patients, but also to support the family members because they are already have gave up of their family patient, because they are always taking care of them. So they are really in a low mood. So patients' families need to be supported, educated, and given the knowledge how to manage their disease. We do not only want to care for patients, but we want to advocate to improve the infrastructure. We want these palliative care services across each hospitals in Mullaitivu and all other districts. And we want to build a sustainable health network in the palliative care. So our project has, over the last 8 months of time, we have reached more than 61 patients, mostly females, and then we have 25 males, and we have 2 children, pediatrics cases. Our patients' age group range from even 2 years to 100 years. So we had a patient 100 year. So it's really nice that we see a wide range of patients. So most patients are located in Pudukkudirpu and Oddusuddan district, if I'm right.
Maritime Patru.
Maritime Patru in Mullaitivu.
And also Mullaitivu area.
Okay. So most of the primary disabilities we see is elderly bedridden patients, and also most who are affected by the stroke and bedridden following the trauma, such as war, road traffic accidents. The main services we offer is first to connect to the social service. So when we first visit to our patient, the first patient we visit in our palliative, we find it not only the medical treatment is important, something that there is a big things to be resolved. We have to look at their social status. We have to look at their financial status. We have to look at their, their environmental hazards and so many things. Not only prescribing medicines and treating the acute problem, something to deal with it many aspects. So that is the palliative care. So we want to connect to the social services. For example, when we visit to a patient, their family members is unable to afford Pampers daily. So we try to connect to an NGO who can provide supplies of diapers to that patient. So that's how we do some connections. So then the next is the disease control, non-communicable diseases, controlling hypertension, diabetes, and all. And then we do some home-based physiotherapy services for most of the patients because they are really need, because some are immobilized for the longer time, and our physiotherapist is doing a great job on doing a continuous care to that patient. And also our palliative care nurse who often visit, because me as a doctor working in the hospital, sometimes I couldn't able to go to see the patient, but these our palliative care nursing officer is doing a great job going there, checking his blood pressure, diabetes, and often updating me and keeping the optimization of the drug. And also we do catheter change and many more. So this is some case I want to share. This is 90 years old Lakshmi. I visited him. His family members came and said that they want some medications. They cannot able to bring their elderly grandmother because they don't have transport facilities. So we have reached their house that on June. And when I see the patient is healthy, but the blood pressure is very in a hike, 240 by 120, and patient is currently on losartan amlodipine antihypertensive drugs. It's not really controlled. So what we do is we do some integration of home-based palliative care service to the hospital-based care service. So I asked the patient to admit immediately, and she was admitted. Over the last 3 days. She stayed in our hospital, and we did whole body assessment. We did the blood checkups to check whether his blood vitals are okay, the blood investigations are okay. We optimized her hypertension, and we had found out she's anemic, and also she had a uterine prolapse. So what we do is we do a multi-specialty care for her, even in the limited resource. We referred to the gynae ward in District General Hospital Mullaitivu for her prolapse, and also we put a very comprehensive follow-up plan how we are going to treat her. And we discharged with a good blood pressure, and she was really happy, and their family members were really happy. So we can see if this patient is staying in her house, when no any medical attention is made, she might ended up in maybe a stroke and being paralyzed, or maybe having an ICH or something with this high pressure. So this is how our service is really making impact in the society. This is just a few examples. So far, what are the progress we have made it is that formation of good palliative care team, and thanks for the funders for funding our nursing officer and physiotherapist, and also we have our public health nursing officer also involved. So we have a good palliative care team. And then the second thing is that when we went for the first visit and we noticed that there is when we do the assessment, we miss many things. So we were not in an organized manner. So we did some research studies. We find some tools across the country, and we across the globe, and then we organized and put together, and we develop our own tools. I think this is the first time, I mean, I can see such tools are being developed here in Sri Lanka. Maybe there is not one which is a benchmark. So we are trying to even further standardize this tool. I will show next. And then we made some good connections and networking with the community leaders and NGOs, with the government sectors to support some wheelchairs, and also that and provide some basic needs like medical supplies and pampers, and many patients identification. We started the patients with one patient, and later, like, with the help of the doctors, bystanders, local health community leaders and healthcare workers, we identified so many patients who never reached to the hospital, but they have multiple comorbidities, then we reach the patients and we are providing the palliative care services. So this is a register book. So when a patient bystanders comes to the clinic and get medications for their elderly patients or who are bedbound in their house, I connect the bystanders to the palliative care nurse, and he maintains a register where with all the information. Then we go to their house, and this is the evaluation tool we have developed. This is a patient information sheet in the left side, and we developed a home visit checklist for the palliative care for the clinicians and also all the health staff who are going. This tool is really a very good comprehensive, like we assess the vital basic signs and also functional assessment. And we do some environmental and living condition assessment, whether the patient is having good lighting, whether the patient is having a good ventilation in their house, when the temperature is adequate, and is there any hazards in the walkway of the patient, and whether we see whether his medical equipments like wheelchairs are functioning properly, whether the bathroom is very accessible to the patients, and we check his emotional well-being of the patients, and we do some recommendations, and we evaluate whether this patient is needing any end-of-life care or physiotherapy or need a good follow-up plan. So this is a database we have following since the beginning, and with the GPS coordinates, we have this to ensure that this this project is sustainable, and whoever comes and take over this project knows that where is these patients are. So we want them to be very sustainable. So far we have did some good networking, and to enhance the sustainability, we had a meeting with the Vellore CMC Medical College and also Hebron in Vellore to find how they do their palliative care services in India. And they are maintaining a good digital system, and they are willing to trial in our project, and they want to offer us for free services on the digital system. So we have a good database, follow up, and everything. And we also had some social and livelihood support from Varod and Divisional Secretary Oddusuddan. And also we are planning to do some research. So this our program is a evidence-based, and also we benchmark it, and we also implement. We can showcase that our project to the rest of the country, so this someone will get benefit. So we had discussed this with University of Edinburgh also. So the challenges we have facing so far is that poor transportation and road access delays the visit and access to vehicles, and we have a limited vehicles. But so far it's not a problem because we used our hospital ambulance. But however, this is not always favorable, because sometimes the emergency patients come. Sometimes we need to return immediately from our home care to the hospital. So the emergency patient has been taken. So transportation is a big problem. And some families really really undervalue the palliative care services. For example, one time I and palliative care nurse went to see a patient. But when we were seeing the patient is bedbound and he died 1 week before. However, when we visit like 2 months before, their family is not cooperative. They are having a chat. And they are laughing, and like they are having their own. They are not even like value the service what we do. And some families expect for more, like for this, when we visit their house, they think that we are visiting so they can benefit it, like money wise or material wise. So we need more doctors to be trained, and more other health personnels need to be trained. And doctors also need additional support to manage these cases along with the clinicals, and we need a good follow-up system. It's not just seeing a patient one time and leaving. It's just we continue to follow up, which is really challenging because of the logistic and also no proper follow-up system. So we are trying to do our best to take this our program to the next level so everyone can get benefited. Okay, thank you.